Welcome, and we're pretty happy to have you here today. Thank you for joining us. Quite unusual. We're actually in Giant Stadium, broadcasting live, and a lot has changed from a year ago. All together, celebrating our research, celebrating lives, being together, and now we are broadcasting webinar. So that's a lot, and the hospital's been through a lot as well over the last 5 months. Today, without any hesitation, how proud I am at Hackensack University. Our hospital has done a phenomenal job during this very stressful time. Just sort of give you some figures and some ideas of the things and accomplishments that we were able to achieve over a very short time. Consider this, today we have 48 ICUs. During the height of COVID, we had 200 ICUs. As of today, we had about 20 people or so needing ventilators. Back during the height of COVID, we had close to 180. We got through that. We discharged over 1,000 patients. I think, learned a lot from that. We directed a lot of different resources for that. But I will say, most impressive to me is that we came out a lot stronger from that. And our commitment to research, to improving patient care, to really advancing medicine has never been stronger now that we've learned so much and we've done so much. So tonight is going to be our first of two-part series on the urology series. Tonight we're really going to focus on prostate cancer. Prostate cancer is the most common non-skin cancer here in the United States of America. In fact, 1 of 9 men will have prostate cancer in their lifetime. And our department is focused heavily on advancing the diagnosis of prostate cancer to make it more accurate, more patient-specific, and also advancing on the different treatment options, both surgical and non-surgical. And tonight, that's what we're going to be focused on and really dedicating this entire event toward is prostate cancer. And for those that you may not know, this month is Prostate Cancer Awareness Month. So it's, I think, a very apropos to have this. So we're going to like to really thank a few folks here. Number one, I really like to thank Dr. Kevin Basralian, my partner. I met Kevin about 4 years ago. He is a source of energy, a source of inspiration, and is a real person that likes to think out of the box. I would also suggest he's a real Renaissance man, a man with many different talents and many different interests. Dr. Olivier Loudig is an associate member of the Center for Discovery and Innovation. I also got to meet Olivier a couple of years ago, and we've been working together very closely with the Center for Discovery and Innovation on different prostate cancer research projects, and you're going to hear about those today. And then last, I really want to extend a sincere thanks to all our generous sponsors today who have allowed this to occur and these 2 seminars to be possible. Amniax, Axonics, Precision Surgical, and Allergan. Again, we cannot do what we do without your generous support. So with that, I'm going to get started, and we're going to talk a little about some new technology on single port surgery. Thanks again for coming and spending this time with us. I'm going to go first today and talk about single port robotic surgery and really how it's engineered for prostate surgery to help us improve outcomes. The prostate itself is a small gland that sits deep inside the body, as you can see here. So the prostate literally lies behind the pelvis, and it is surrounded by the bladder, as well as behind it, the rectum. Also, the prostate lies between the urethra and the bladder itself. So some pretty important structures sort of surround the prostate. And then finally, the neurovascular bundle, the nerves that allow men to have sexual intercourse as well as control the urine, run just next to that prostate. So as you can imagine, getting to the prostate is difficult because it's so deep in the pelvis, but also it is surrounded by some very important and critical structures. In many ways, single port robotic surgery is designed and engineered to deal with the exact problem, getting into a deep, narrow space and performing very complex surgery. Just like robotics of before, the surgeon sits at a console away from the patient remotely and controls the robotic arms. However, with this technology, all the instruments go through a 1-inch incision. The surgeon controls the camera, which can be rotated, controls 3 instruments that articulate and move just like the human hand. And in fact, the surgeon can move the entire instrument 180 degrees to get into those nooks and crannies. So the engineering behind this is really designed to get into these narrow angled spaces to perform complex and advanced surgery. And there's some other added benefits. Number one, we now can perform this very delicate surgery through just a 1-inch incision hidden in the belly button. We no longer have to enter the abdomen like we did with the previous robotic technology. We can stay outside of the abdomen. That prevents any inadvertent injury to the abdominal contents, but also we no longer have to pump air and CO2 into the abdomen, which sometimes can cause a long recovery. And it's been shown now that this allows us to have less pain and a quicker return to normal activities. Now, I'm going to go inside the body. I'm going to show you a small portion of the surgery where we reattach the bladder to the urethra after the prostate's been removed. If you don't like to look at surgical videos, now would be a good time to get a drink. However, if you do, it will be very short. So here we are putting a needle through the bladder. Imagine that needle is literally a 0.5 millimeter wide. The suture is literally the size of your hair. Look at the precision that we can use with this technology to place needle exactly where we want it. The size of that tube, that urethra, is just 1 centimeter. And the wall of the tube is only 1 to 2 millimeters. And again, you can see the precision, you can see the visualization, you can see the control that we have with this technology, which again is just 1-inch incision. So let me share with you our experience here at Hackensack University Medical Center utilizing single port surgery for prostate cancer or prostatectomy. We acquired this technology in February of 2019, about 18 months ago. We were the first of only 10 institutions in the entire world to get this, and currently we're only one of about 50 that have it. And we have one of the largest series on robotic prostatectomy. I put a comparison here on this slide between our robotic single-port prostate cancer surgeries and compared them to our multi-port surgeries done during the same time. As you can see, we've done about 1/4 of our prostate cancer surgeries with the single port and 3/4 with the multi-port. Interestingly, the operative time is quicker with the robotic single port versus multi-port. Our length of stay is also less. About 20% less time is required in the hospital when doing this with a single port. Our ability to get those patients out the next morning, discharged before noon, is equally good, about 70%. We have no transfusion rates. All our patients go home. And interesting, our readmission rate, the need to come back to the hospital, is only 2% compared to 4% with multi-port. And mortality is 0. So as you can see, we are achieving excellent results with this new technology, and in some parameters, even better than with the older multi-port technology. But let's be clear, there are limitations. This technology is not for everyone. We have learned that it is not very good on patients that are obese with BMIs greater than 31. We also learned that it's not very good for large prostates 75 grams or more. And in patients with advanced disease that need what we call an extended pelvic lymph node dissection, removal of lymph nodes surrounding the prostate, we also know that the multi-port is more efficient and in some ways better than the single port. So what I tried to do over the last 5 minutes is really show you the evolution of prostate cancer surgery in the last 15 years. Consider this. Just 15 years ago, we had to make an incision approximately 6 to 8 inches long through the abdomen, split the muscle, put headlights on, work into a deep hole with poor visualization to do prostate cancer surgery. Then we had the introduction of the multi-port robot, making this operation significantly less invasive, using only 5 small incisions. And now today, we have further advanced and transformed the way we're doing surgery so that we can do this operation as safely and in some ways better by doing this through just a 1-inch incision hidden in the belly button. I want to thank you for listening on how we're transforming prostatectomy surgery in patients here at Hackensack University Medical Center. So I hope you really enjoyed that talk on single port. We have a couple more talks to come. One of the nice things about being live and being on this webinar is we really get a lot of questions that have come in. I can actually, during the talk, I saw a bunch of questions that have come in that need to be answered. And unfortunately, we're not going to answer all of them tonight. Otherwise, we'll be here for probably 2 hours, not 40 minutes. But I'm going to try to answer a few. And any questions that we don't answer, Stacy will make sure that we get it all out to you on paper. So I'm going to pick 2. The first one is, why do some people have a high PSA and the number, but they don't have cancer? They can't find cancer. I think that's a really good question. I think it's something that's going to help lead up to why we're so interested in prostatome technology in terms of diagnosing prostate cancer. But PSA is a protein that's made by any person that has a prostate. So it turns out that PSA is not a very good tumor marker. It doesn't tell us if you have cancer or not. It just tells you have something going on in your prostate that could lead to or could involve cancer, but it could be other things. Inflammation can lead to an elevated PSA. Having just a very, very large prostate. Someone has a 30-gram prostate versus a 100-gram prostate. That larger prostate will make more protein, will have a higher PSA. There are just certain people that leak more PSA into their bloodstream than others. And there's obviously those with cancer. So PSA itself is not sort of the all to end all test. And that's why we've sort of advanced some of the technology that we're using to better diagnose prostate cancer and really understand who we need to even do a biopsy on. Another question. Okay, this is a great one. Question number 2. Is my understanding that because it is a slow to grow cancer, prostate removal in older men is often not recommended? Do the new surgical options change those calculations? That's a great question. And first of all, we really tried to identify patients early on in terms of identifying their risk categorization. Prostate cancer is not binary. If you have prostate cancer, there's not one treatment for everybody. The most important thing we like to do, or one of the most important things, is really understand, are you a very low risk prostate cancer, low risk, intermediate, or high risk? So a very low risk and low risk prostate cancer, especially in men over 70 or 75 with a 15-year life expectancy or less, we will tend to observe them. And that is, and using HIFU and using our new technology of single port really doesn't change that calculation. If you don't have to operate and it's going to not benefit the patient, we're not going to do it. Doesn't matter how minimally invasive that procedure is. And again, I just want to remind you, if I didn't get a chance to answer your question, please look out for the post-webinar email where we will have all the questions answered, but also give you more information on our upcoming seminar in the next couple of months. Now, without any further ado, I'd like to bring the next presentation to my colleague, Dr. Kevin Basralian, who's attending at Hackensack University Medical Center. He's been a staple of our community for 30 years. I don't think there's anyone on the line that doesn't know Kevin, either personally or know of him. He's just a wonderful physician, a wonderful human being, and he's going to focus today on using high-intensity focused ultrasound for the treatment of prostate cancer. Take it away, Kevin.
Hi, I'm Dr. Kevin Basralian. I'm here to talk to you about diagnosis and treatment advances in prostate cancer at Hackensack University Medical Center. First thing I'd like to talk about is prostate fusion biopsies. We used to do biopsies of the prostate for men who had elevated PSAs, doing a random biopsy. 6 to 12 biopsies were done. we missed a lot of cancers. If you look at the diagram on the monitor, you'll see that the green area is an area of cancer found by MRI, whereas the other candlesticks on the bottom really missed the area of concern. This targeted biopsy is what I'm going to talk about today, which is done by MRI. I'd like to talk to you about fusion biopsy of the prostate. Patients have an MRI performed, which is then put into a machine, a specialized machine done at Hackensack known as a UroNav. We can then direct biopsies based upon that information in real time. That is, the MRI is on one monitor. We have an ultrasound probe, which we look at the prostate in real time, and together we can fuse or overlay those two images, directing our biopsies to suspicious areas. We could not do this before, and we've increased our accuracy by 100% by using targeted biopsies. Biopsies are done with a team of radiologists reading them, finding a system called a PIRAD system. We find those that have suspicious lesions, and along with dedicated equipment and sedation for patient comfort, we can guide our biopsies directly to the areas of suspicion, thereby getting much more accuracy. So what happens after we have a diagnosis? Well, we have to have treatments, and we have many treatments for prostate cancer. But a specific treatment I want to talk about is called HIFU, high-intensity focused ultrasound. Developed in the 40s for brain lesions, adapted in 1990s for prostate, this machine allows us to take ultrasound waves of a short distance, concentrate that ultrasound waves into energy, and kill the cancer cells. It's analogous to having the old magnifying glass 4 or 5 inches away. You can burn your hand or the paper, but in between you don't. Same with the ultrasound. Ultrasound waves pass through tissues harmlessly, but where they come together or concentrated, they generate heat. That heat is then allowed to kill tumor cells without damaging other cells, and we can direct that very accurately. The procedure is an outpatient procedure. It has no radiation, no surgery, so blood loss is not a problem. Patient comfort is easy. Patients go home the same day with a catheter. Patients' quality of life is maintained. Their sexual function, urinary control, and their daily living is unchanged. And we have excellent disease-free intervals. It's been studied for years. We have some great data on this. How the procedure done? I have a diagram here. You'll see on the left side of the prostate, the cancer is identified within the gland. We can then, with a probe in the rectum, generate ultrasound waves, which go directly to the cancer cells, and we can treat that area specifically and accurately. The patient's done with the procedure afterwards, and what you have next is the area of treatment, either the left side, right side, or in some cases, the whole gland. I'll talk to that later. This transducer, which is in the probe in the rectum, can be two-directional, so you can make sure you're getting the right area to treat. Ultrasound heats tissue specifically, almost a little like an area of long-grain rice, 3 by 9 to 12 millimeters. That's a small area that can maintain accuracy. These areas are pre-planned using the UroNav machine, the radiologist, and a surgeon with experience. So is it for everybody? No. There are some limiting factors. One is the aggressiveness of cancer cells. Very aggressive cancers might be treated with more aggressive treatment. Volume of cancer cells, the amount of cancer cells, and the location. So these are the things we have to remember, that every patient is not a candidate, but 20 to 30% of all diagnosed patients are candidates. Who are the potential candidates? One, patients with localized lesions. They're within the gland. We know where they are. We've documented it with the UroNav system, the MRI. We can treat them locally. Second, patients, ones who've had prostate cancer, radiation failures. Cancer comes back. 40% of those patients still have cancer localized to the prostate. We can treat them. And third, patients who are just being monitored and watched. they're not comfortable, we can do a minimally invasive without changing their lifestyle, they are a great benefit to be treated. So as you can see, we have some new treatments. They're excellent, and we're the only institution in New Jersey to have this technology. Thank you for listening. I hope everybody enjoyed that talk on the diagnosis, new treatment modalities. Very exciting, and I'd like to take a question or two that came in during the talk. First question is, do we have any videos on HIFU? Because watching stagnant pictures are one thing, but seeing a video might help. And we do have a short video that we'd like to show you right now.
High-intensity focused ultrasound, or HIFU, is delivered via a transrectal probe that is securely positioned in the appropriate anatomical orientation at the beginning of the procedure. In preparation for ablation planning, the Sonoblate imaging transducer maps the morphology of the prostate gland in real time. This allows the physician to create a customized plan for the procedure in multiple ablation zones. The device makes use of integrated biplanar ultrasound imaging of real-time ablation planning, monitoring, and post-ablation imaging. Sonoblate features a two-sided transducer, allowing customizable applications with focal distances at either 4 centimeters or 3 centimeters. Precise focusing of ultrasound energy during a HIFU procedure rapidly elevates the temperature of the tissue in the focal zone, resulting in tissue destruction. Intervening tissue between the transducer and the focal zone remains unharmed. The result is an accurate and repeatable lesion at the target sites that are monitored by the treating physician in real time. All the ablation zones are pre-planned and checked by the physician prior to starting the HIFU procedure. Every ablation lesion is specifically planned around the identification of critical anatomical structures, such as the prostate capsule, seminal vesicles, rectal wall, and neurovascular bundles. HIFU is non-surgical and radiation-free.
Hope you enjoyed that as a brief video, but it does give you some insight. Another question that came up is, when you have prostate cancer, and it was spoken by Dr. Stifelman about the robotic prostatectomy, how about patients who have failure of prostate cancer treatments, radiation failures, for example? And the question is, how do you treat them nowadays? You take the hormones away and just give them radiation, or are there any new advances in the treatment of recurrent prostate cancer after radiation? So there are some new treatments. Prior to the last year or so, there was the standard treatments, but now we have new androgen receptor inhibitors, which means it inhibits the cancer. Instead of every patient having radiation right after a recurrence, which is about 20 to 25% of patients, we now have drugs like apalutamide, which is a mouthful, but they treat the cancer when it's localized. We try to hold off on radiation and androgen ablation, which removes the hormones, specifically testosterone, because there are a lot of long-term side effects on those. So the longer we can hold off additional treatments, the better it is for our patients. I hope that was a little bit helpful. And I'd like to introduce Dr. Olivier Loudig, who is going to talk about new innovations. He's the associate member of the Center for Discovery and Innovation. And we have some fantastic studies underway at Hackensack, which he will speak to on at this time. Doctor?
Thank you both for your presentation. My name is Dr. Loudig. I am a scientist at the Center for Discovery and Innovation, and I've been working with Dr. Stifelman, Basralian, and Munver for now a couple of years, and we have set up studies, and I'm really excited about sharing some of the aspects of the study that we are conducting and give you some information. So as you clearly saw, the Department of Urology uses state-of-the-art technologies to treat its patients. At the Center for Discovery and Innovation, and more particularly in my laboratory, we're using novel technologies to see if we can improve early detection and screening of prostate cancer. How do we do that? So one of the important aspects of this presentation is to introduce you to something that we call exosomes. You probably don't know about it, but I'm hoping that by the end of this presentation, you will understand what are exosomes. So here, I'm going to show you how exosomes, which are nanoparticles that are found in the blood, do and what advantage they can provide. So here, you will see exosomes being formed inside this tiny endosome here. Those are the little exosomes. They are formed inside the cells, and there's a fusion of the membrane that produces them for release in the circulation. They contain information, DNA, RNA, protein, and this information is inherited from the cell of origin. Interestingly, too, they have surface protein that gives an identity of the cell where they're coming from. Here you see an exosome that has been circulating that enters a recipient cell. Here's an example of a cancer cell producing exosome, releasing those exosomes in the microenvironment or circulation, and changing the fate of a neighboring cell. So what you need to remember when you look at exosomes throughout this presentation are a few facts that I'm going to name here. First of all, exosomes, like I said, are released in the circulation. As I said also before, they have protein on their surface that are inherited from their cell of origin. Exosomes also contain a specific set of information from the cell of origin, an encapsulated portion of information that is retained in the exosome. When they circulate, it's not released, it's not changed. So it makes it a great target because you can remotely, if you access this information, have some idea of what was produced in the cell at the time it was released. Exosomes are produced by most cells, normal cells, cancer cells, and most of the cells of the body. Exosomes are secreted in a larger number by cancer cell, which is an advantage and an inconvenience for the disease, but it's an advantage because they are more detectable than normal exosomes. Exosomes, as I showed you on the last few images of the video, enter recipient cells. They enter the recipient cells with specific marker on the surface that allows them to be addressed to a specific cell so we can purify them. Exosomes from cancer cell contain different information. That's what makes them more interesting because we can, when we look for cancer cell, determine the information that we are after. Exosome can be purified using antibodies to target their specific surface protein. So how do we purify and identify exosome from a pool of circulating exosome? Well, simply because they have specific protein that inherited from their cell of origin. And if we know this protein, we can use antibodies that are molecules that capture specific protein, and we can purify them. So now let's look at prostate exosomes, and it's called prostasomes. Prostasomes are synthesized in the prostate, and they are released in the seminal fluid and solely in the seminal fluid in healthy individual. When you look at cancer, now you have a tumor with a vasculature that is leaky. So some of these prostasomes that are synthesized in the prostate have the ability to enter the circulation. So now in a cancer patient, you have prostasome in the circulation that you shouldn't have. So with a proper tool, if you are equipped to purify those exosomes, you can potentially diagnose prostate cancer without any of the tests. So here is a more intricate picture of how we actually run this assay. If you look at the top of these slides in blue, you see what I described so far as in prostasomes. This prostasome contains specific protein, like I said, and you have on the left a list of 4 of the major proteins that identify prostasome from other exosomes circulating in the blood. So we use antibodies to recognize these specific surface markers. And once we purify those prostasomes, we can extract the information that it contained because this information comes from the cell where they were secreted from. So we can potentially look at a cell's content without having to access it. So on the right, you see what we call a heat map. And this heat map contains a list of genes. Each little square is a gene. The color of the heat map determines the intensity of expression. So within one experiment, we can see the expression of thousands of genes and determine, based on the profile of expression, if we're dealing with a normal cell or a disease cell. So just for the purpose of this presentation, I put a tumor prostosome at the bottom in purple. And as you see, there's a question mark, because we are still trying to figure out if, by looking at prostosomes circulating in the blood, we can capture and identify specific information. And that's what we're trying to achieve in my laboratory. So how does the assay work? The assay is pretty simple. You have a magnetic bead with an antibody that captures all exosomes circulating in the blood. That's the first step. Second, you use that combination of antibodies. Each of these antibodies have a little piece of DNA. And when they are in the proper combination, they hybridize to a piece of DNA that contains fluorescence. If you have 3 signals of fluorescence here, they are yellow, red, and green, then you know you have identified a prostosome. And we have something called a sorter that allows us to separate prostosome from other exosomes. So then we can extract information and look at their content. And that's what we're doing in my laboratory. This assay was designed by a collaborator at Uppsala University. So what is the study that we have established with the Department of Urology and Dr. Stifelman, Basralian, and Munver? This study includes 600 patients, or 600 individuals, 300 that are controlled, that are healthy, and 300 that are patients that have been diagnosed with prostate cancer, because the purpose of this initial study is to determine if this new assay is reliable and we can pinpoint the samples that have signs of prostate cancer. So we will collect blood, we'll separate the plasma, we will perform the assay, and we will see if we can accurately diagnose prostate cancer. Once we have the prostosome purified, we will extract the information and perform next-generation sequencing to identify if there are specific biomarkers that are associated with different stages, different type of tumors. The idea is to stratify patients without having to do painful biopsies. So what are the goals that we are aiming to reach in the next year? We're trying to complete this pilot study, apply for federal funding at the National Cancer Institute, so we can validate the molecular assay in the Department of Urology at Hackensack University Medical Center. So we can establish a state-of-the-art prostate cancer detection assay in the Department of Urology. I wish to thank all the people that have helped so far, and I'm hoping that this study will soon reach completion. Right. Well, thank you for listening. I want to go through a couple of questions that we received. There is a very technical question, but I'll try to address it with different answers. So that first question says, describe your clinical pathway for utilization of biomarkers, confirm MDX, select MDX, needed genetic testing for PARP inhibitors. Okay. So what confirm MDX is basically a DNA methylation assay where you can sensitively detect the presence of a tumor within an area based on changes that occur to the DNA. It's more for advanced cancers. The other assay, Select MDX, is also a non-invasive urine-based test that tests the expression of 2 genes. But again, this assay is more ideal for advanced prostate cancer. There was a portion of the question about PARP inhibitors. So these inhibitors are more targeted toward a specific type of prostate cancers, and especially the ones that have BRCA mutations. So what we have here are assays that have been designed and tailored for specific stages, specific situation with prostate cancer. But what we're trying to achieve with this test is a little bit different. We, in my lab, believe that if we can detect cancer early enough, we can actually prevent it from occurring. So the idea would be to to detect it at its early stage, which is, I believe, something that has been very difficult, especially with the PSA test, because it's quite noisy. It relies on protein detection. So by using prostazome, by looking at their content, RNA, DNA, we're looking at molecules that we can amplify. And by amplifying molecule, we can detect them at very low concentration. So we can potentially detect them much earlier than some of the tests that are currently on the market. There is another question here. Okay.
I'm going to jump in. We could do that, right? So, what I'm understanding here, and I want to make sure I understand it the same way everyone understands what I understand. Essentially, what you're suggesting is that every prostate cancer cell, when the exosome is released from that prostate cancer cell, has a signature in it. Within that exosome, it all came from the cancer cell. So there's a signature. So what this test potentially can do, and what you're trying to do in your lab, is to, number one, identify patients with prostate cancer cell much more specifically and sensitive, with much higher sensitivities. Because now you know that when you find these exosomes in the blood, they must be coming from prostate cancer cells, and you can confirm that by opening up the exosome. But in addition, it sounds to me that you're going to be able to take that genetic those proteins, that information in the exosome, and actually stratify the patient without ever doing a biopsy, without ever doing an MRI, without ever doing a rectal exam, and basically tell them you're a low-risk cancer patient, you're a moderate-risk cancer patient, you're a high-risk cancer patient, based on what's inside that exosome. Am I hearing that correctly?
Yes. So, I don't want to put too much hope into this, but I'm confident that the information that comes from the cancer cell is specific to the cancer cell, and the cancer cell is obviously different to the normal cell. So that's really the question. Can we non-invasively, remotely capture information that will tell us what's happening in the prostate? So it seems a bit futuristic, but I think we have the tools and the sensitivity, and that's what we're trying to achieve, really.
And the science. Amazing. Absolutely amazing. I know you have another question, so I'll let you answer that.
Okay, yes, just a quick question. Somebody asked when were exosomes discovered? So exosomes actually have been known for almost 30 years, but as far as their function, it's changed in the past 10 years. Until 10 years ago, people believed that exosomes basically were just a portion of debris that the cell would generate to release and to get rid of. But as it turns out, with many of the studies on cancer cells, we found out that this information, when addressed to a proper cell, can have specific effect. One of the most described effect is the preparation of a metastatic niche. Exosomes circulate in the blood, will be addressed to a tissue, and will prepare the tissue for metastatic cells that are detached from the tumor to access this tissue and start a secondary tumor. Wow. So that's why there is invaluable information in those exosomes, and we're trying to decipher every portion of it.
So not only could you identify the cancers and potentially stratify them, but if you can get them out of the system or find a way to destroy those exosomes before they re-enter another cell, the host cell, then you can, in theory, potentially stop metastasis.
Yes, so that is one aspect. And one other aspect of it is therapeutics. Can we actually manufacture exosomes that will be addressed to the cancer cell and destroy them? Yes. So, there's a lot going on with exosome, and I think in the near future, people will start hearing more and more about it.
Well, clearly an extremely exciting field, and we are very fortunate to have you on our team and doing this amazing work at the CDI, and we love supporting you and helping you, and I can't wait to look for what's more to come. So, the way this works is it's pretty laid back. We're gonna plan this a fair amount by year. So we said it was going to be about 45 minutes or so. We're kind of at that point, but there's so many questions coming in right now. There seems to be so much engagement. There's so much interest. that we're just going to go and just hit on a few more questions. And again, we appreciate your time and you being here, but I do want to hit on a few more questions before we wrap it up. So this one looks like it's going to be answered by Dr. Basralian. And the question is, Kevin, does HIFU ever not cure the cancer? Right? It sounds like amazing technology you showed us here. Like this stuff sounds like the best thing since sliced white bread. If I had prostate cancer, was HIFU. Does it ever not work? And if it doesn't, Kev, what do you do next?
It's a great question because we all want to have an absolute answer to a question. Does this always work? I'll never have cancer again. Is this 100%? Unfortunately, even with Dr. Loudig's work, we still haven't gotten there. We always have recurrence rate. There is no treatment currently that has no recurrence rate for cancer. And that's true of most cancers. When cancers are first diagnosed and then treated, we do follow-ups every serial or every 3 months, 6 months. We have a protocol to follow, track when patients' PSA rises. The nice thing, in my opinion, about HIFU is that we have not burned any bridges. If cancer does reoccur, and that's either done by following PSAs, repeat MRIs, repeat targeted biopsies, which I've discussed, we can go back and patients and treat them again with either HIFU. We have surgical options and we have radiation options. One of the things about cancer treatment, we're diagnosing patients earlier and treat them sooner, those that are appropriately need treatment. So we haven't burnt any bridges, as we say, that we can always go back and treat patients again with careful follow-up, which is communication between the patient and our institution and the physicians. I think that's how we do it.
Yeah. I mean, I think one of the things I would sort of stress and focus in on is, one of the goals of being a patient at Hackensack University Medical Center, especially with prostate cancer, is that you're not a number, you're not a cancer, you're a person, number one. But as importantly, there are many different choices with a tremendous amount of factors that go into that choice. And our focus is allowing every patient to get, be individualized, basically, and have individualized care. We know with prostate cancer, there is no such thing as one hammer for all nails. There's lots of different treatment options, and there are reasons to do them and not do them. So I think that we heard a lot about that today. I think we're going to wrap it up because it is getting around that 45-minute mark, and I want to be respectful of everyone's time and give you some time to enjoy your pretzels. And if you have more questions, you can write those in and send them to us. If you've already sent them in and unfortunately weren't answered, we're going to answer them for you. So sometime in the next week or so, you're going to get another email about the webinar from this, and we are going to answer them for you. Before I stop, I want to just do two more things. I was kind of bringing around the horn a little bit, and I want to ask each of my partners here, what is their biggest challenge right now, and what are they most excited about over the next year? Specifically, forget, you want to break 100 in golf, I get that, or you want to stop wearing a mask, that's great. But what's, I guess, from an academic side, research, we'll start with you, Olivier. What's your biggest challenge right now, and what are you most excited about?
Well, I mean, I don't want to sound too obvious, but we've been slowed down significantly in research. The Center for Discovery and Innovation was open during the pandemic, and we switched our operation to look for biomarkers for COVID-19 patients. We looked at immunity, so we still continued some work, but we had to shift our efforts in not the direction that we had intended to be initially. So that what I'm excited about is really getting back to that project and moving forward.
Kevin?
I'm excited about the same thing as Olivier said, but I think the challenge is getting patients to come back, feeling careful and accepted, and that our institution is doing a good job, which it is, keeping everything clean. We have a very good services that come in. Our offices are clean. Come back into the office, come and be workup. Don't omit your follow-ups. And I think that's the big challenge, getting patients back. As far as new technologies we talked about, I think they're exciting, and we have a future ahead.
Yeah.
Prostosome and other studies. Thank you.
That's great. That is super. So we're gonna wrap this up. Again, I want to thank everybody for their time. And again, I'd like to give a sincere thank you to everyone that joined on this part two-part webinar in urology. I know I enjoyed myself today. It was great to hang out with some people, even though being even socially distanced, it's great to hang out. Again, I want to thank our sponsors, Amniox, Axonics, Precision Surgical, and Allegron for their philanthropic support and commitment to research, education, and technology. And I think as you heard, we've gone through a lot over the last 6 months, and we have come out stronger, certainly in terms of our determination, in terms of our ability to pivot quickly, in terms of our ability to, work in a stressful environment and get through that. But at the same time, we're also come out committed more than ever to research, education, and to teaching. And so this is where we ask you to help us be able to do the things that we need to do and want to do to make sure we can continue to promote that within our department. And I think he's seen a lot of the success that we've had here at Hackensack University Medical Center. There's no reason, it's not a question why we are the #1 urology department in New Jersey, ranked by US News World Report. We want to be the #1 in the metro area. We do that by being collaborative. We do that by being courageous, but we also do it with the help of you. So again, consider helping us so that we can help you. And again, I want to thank you again. We'll get back to you, and I look forward to seeing everyone at our next virtual urology series, and more to come on that. Thank you so much, and have a wonderful evening.